Good afternoon and welcome to the second webinar of the K-HEALTHinAIR project titled Translating Indoor Air Quality Research into Better Health Outcomes. I am Natalia Allegretti, Senior Innovation Manager at the Global Health Connector. The Global Health Connector is managing communication and dissemination actions within the K-HEALTHinAIR project, and I will be moderating the webinar today that I hope you will find very interesting. Before jumping into the discussion and presenting our speakers of today, just few housekeeping. So the webinar is recorded and the session will be also showcased on our communication channels after the events. During the discussion, please turn off your camera and mute your microphone, and then you will have a specific session dedicated to questions and answers, and you can use the chat function that you can find at the bottom bar to put there your questions, and we will share them with the speakers during the Q&A session. And if you need any subtitles during the discussion, you can click on show subtitle captions and you will have automatic subtitles. So the program of today is quite full of very interesting presentation about the research that we are implementing within K-HEALTHinAIR and some implications in relation to human health and well-being. And I have with me today Ruben Gonzalez Colom, a senior researcher at the Institute of Biomedical Research, Auguste P. Sonnier. Alba Gomez Lopez, belonging to the same institute in Barcelona. She's a nurse, case manager, and PhD candidate. And then we have Simon Deled. He's again a PhD candidate, and he's working at the Erasmus Medical Center in Rotterdam. And also we have a very important and let's say touching testimony from one of the patients that are involved and are currently testing our solutions developed by the K-HEALTHinAIR project, Alfonso Miguel Vinueva Juarez, who is a patient affected by COPD. He couldn't not be with us today, but he wanted to leave his word and share his word with all of you. So we will start the session today by listening and watching his recording, and then we will jump into the discussion of and presentations of our speakers today. So I will stop sharing my screen now, and I kindly ask my colleague Dimitris to put the video on. Thank you.
Hola, me llamo Alfonso Viñuela, soy de Barcelona, tengo 69 años, estoy casado y padezco EPOC y deficiencia de alfa-1 antitripsina, ALDAT. Tengo una hija de 35 años que también tiene deficiencia de alfa-1 antitripsina, aunque genotipo SZ, no ZZ como yo. En mi caso, tras sufrir complicaciones pulmonares año tras año, era fumador, medio paquete al día, desde los 21 a los 40 años, pero aún así todo dejando de fumar, pues mi neumólogo en aquel entonces, doctor Serrano, me hizo la prueba de alfa-1 antitripsina y cuando estadio positiva, ZZ, me derivó al doctor Miravilles, neumólogo especialista en este déficit y en el Sistema Público de Salud, el Hospital Clínico al principio, Hospital Valdebrón ahora, y desde 2001 el equipo del doctor Miravilles ha seguido mi evolución de mi EPOC y mi deficiencia de alfa-1 antitripsina, con la doctora Amaro, que es mi neumóloga de referencia. Recibo tratamiento cada 15 días con un inhibidor de esta proteína, del alfa-1, y complemento mi medicación pues, con inhaladores, corticosteroides, acitromicina 3 veces por semana, un antibiótico de mantenimiento antiinflamatorio, y cuando tengo episodios, pues nebulizaciones de ipatropio con salbutamol. Antes de que me diagnosticaran EPOC en el 2000 y deficiencia y el déficit de alfa-1 en 2001 o 2002, Era un profesional activo en consultoría, en formación, esquiaba, montaba en bicicleta, me gustaba correr, también caminar por la montaña. Pero claro, desde el diagnóstico, que no fue ni rápido ni fácil de asimilar para mí, seguí siendo una persona activa, pero año tras año pues me he ido sintiendo más limitado, por lo que en 2018 tuve que dejar de trabajar activamente, dejar de coger aviones, trenes, madrugar, viajar, etcétera. Y bueno, y desde entonces pues colaboro con asociaciones de pacientes, LOBEXER, fundación de la que soy patrono, APEPOC, que soy coordinador en Cataluña, y Alfa 1 España, de la que soy asociado. Esto me permite también pues, socializar, conocer a otros pacientes, que es muy importante. Es muy importante dentro de un tratamiento holístico de cualquier enfermedad, al igual que tomar la medicación pues, de forma correcta y constante, hacer actividad, tener una buena alimentación, pues muy importante socializar, grupos de apoyo, compartir, comentar, no sentirte solo. Colaboro también en diferentes estudios, entre ellos el de K-HEALTHinAIR, que mide mis constantes diarias en relación a un dispositivo que controla la calidad del aire en mi domicilio, y mi reloj que envía mis constantes diarias a este sistema. En cuanto a actividad física, pues ahora me limito a una rutina de 1 hora al día en bicicleta estática, algo de ejercicio con pesas también al acabar esta rutina, y 2 días a la semana hago fisioterapia online con un programa de la Fundación Lodexer. Y cuando hace buen tiempo, cuando el clima lo permite y las variables atmosféricas son propicias, pues salgo y doy paseos por la calle. En Barcelona, como es una ciudad con calles empinadas, lo que hago es caminar cuesta abajo y usar el transporte público para volver a casa. Y si he de hacer esfuerzos, pues siempre llevo el oxígeno por la calle, por si pues lo necesito en un momento determinado, pues para no forzar ni mi corazón ni mis pulmones. Entonces, bueno, me ayuda este concentrador de oxígeno suplementario. Y no me quejo por mi situación. Soy muy afortunado de contar con este tratamiento, con esta medicación, con los médicos que me controlan, y siento que llevo una vida plena en muchísimos aspectos. O sea, no pienso en el mañana, el futuro es ahora. Yo no sé cuánto tiempo podré seguir llevando una vida activa, y entonces quiero pues hacer todo esto, cuidarme para compartir este futuro con mi esposa, que es mi mejor amiga y mi cuidadora. Y le agradezco mucho a Janina pues, el cuidado y la compañía desde hace años que me ofrece. Y también agradezco a mis amigos, a mi familia, asociaciones de pacientes que nos apoyan, profesionales de la salud, médicos, hospitales, laboratorios que investigan para encontrar curas para nuestras enfermedades. Sin ellos, sin su trabajo, sin vuestro trabajo, sin vuestra compañía, sería muy difícil poder seguir adelante. Y lo hacemos pues, gracias a todo este sistema. Muchas gracias, y contar conmigo para lo que podáis necesitar. Un abrazo a todos. Cuidaros mucho. Hasta pronto.
Thank you. Very insightful and very touching, I would say, testimonial from our patient, fully involved in our activities. And yeah, maybe Ruben, you can tell us something more about the research that we are implementing right now within the project, and how much the data that we are gathering can tell us something more in terms of correlations, let's say, between indoor air quality and our well-being and health status. The floor is yours, Ruben. Thank you.
Thank you, Natalia, for the introduction. So, as Natalia said, today I'm going to talk about indoor air quality and respiratory health, and I will show you the preliminary results of our study. So I assume that, yeah, I can pass the slides also. So the first question that we need to answer is why does indoor air quality matter? So indoor air quality is important because all of us spend more than the 80% of our lives indoors. And indoor air quality matters because everyone is exposed in a greater or a lesser manner to a different myriad of indoor pollutants. resulting from different activities that we can conduct in our daily lives. And it's also important because it's well acknowledged that being exposed to a poor indoor air quality can have a negative impact in our health. But what does the science tell us about indoor air quality? First of all, I would say that our studies or the results that I will present later on are rooted in three well-acknowledged sources of scientific evidence. The first of them is that exists a positive relationship between the exposure to poor indoor air quality and the development or progression of the disease towards some autonomic dysfunctions in patients or in vulnerable populations that can result or can be exacerbated in patients with asthma and COPD. Then another source of evidence is related to the benefits of reducing the exposure. More recently, we have been proving that reducing the exposure may alleviate the symptoms and reduce health risks in vulnerable populations. And finally, the technology as an enabler. So the recent advances in technology, more related in terms of sensing, so have allowed us to generate sensors and monitors that are precise enough to monitor indoor air quality at homes at low cost. So those are the three main pillars in which we built on top of that our investigation. So what did we want to investigate? First of all, the feasibility of using this low-cost technology to monitor indoor air quality at home from the clinical point of view. Second, we wanted to know what do our patients actually breathe at home, which pollutants are the most common, which are the pollutants that are more exposed to. And finally, if we can use this information to prevent severe respiratory episodes. So having all of this in mind, we formulated this question to ourselves. So should household air quality monitoring be considered in selected asthma and COPD patients? So you can find full access to this publication. That is still in review process, but the preprint is also accessible in medRxiv following this URL here, if you want to know more about that. So what about our study? How did we do it? So we performed what we call ambispective study. And I say ambispective because it has a prospective part and a retrospective part. So we characterized the indoor air quality in our patients' homes during 2 months. And then we observed what happened during the year previous to this assessment. And we put attention to 2 specific outcomes. So pulmonary exacerbations required unplanned hospital admissions and all-cause emergency room visits in order to see if there is a correspondence between the utilization of healthcare resources and the indoor air quality. In terms of indoor air quality, we measured 3 different parameters: CO2, formaldehyde, and particulate matter. And we categorized the exposure to these different pollutants according to the GO AQS thresholds, having a threshold for low exposure, for moderate exposure, and for unhealthy exposure. So as I said before, we explored 3 different things: the feasibility of the approach, the results, the findings, and finally, our proposal from the clinical point of view, if this information is useful or not for managing these patients. So regarding the first one, how well did the sensors perform? That's the key question. And I will explain what worked and what didn't. So first of all, the sensors that we used, we think that have a strong performance in terms of precisely detecting and estimating concentrations of particulate matter and formaldehyde with a stable and reliable patterns. So we observed a stable and reliable pattern, but have some key limitations. The first of them is related to the VOC sensing, that is specific and is prone to overestimate the measures and susceptible to cross-interference. And we experimented also some issues for long-term use of these sensors related to the Wi-Fi connection, the power issues, and some sensor malfunctioning. So this last thing have made us to formulate which is the best way to use these sensors from the clinical point of view. And we identified that the patterns, once identified, remain stable. So our proposal here is to use these sensors for short and targeted indoor air quality assessments rather than long continuous monitoring. And it's very useful for screening and also for checking the effect of a specific interventions targeting to improve the indoor air quality. And then other future improvements that can be done in sensing area is adding to these sensors some oxygen sensors that can be indicators of some pollutants that can amplify the airway inflammation and also improve the VOC's specificity. Then what did we find inside people's homes? So I'm presenting here a table, but I want you to pay attention only to 2 columns, or at least 1 column and 1 row. In the first column, we have the concentration or the frequencies, the relative frequencies of homes that that falls into the low risk category. That means that the complementary percentages or frequencies are homes that follow as average into one of the 2 risk categories. This is very relevant for particulate matter, in which the 40% of the houses screened has a problem with this pollutant, and the other one is formaldehyde, that the 15% of the houses manifested some problems with this kind of pollutant. The other row that I wanted to show you is that one that illustrates very well the relationship between smoking at home and having more pollution in terms of particulate matter. So this is one example of that. So where do fine particulates come from? Most of them from smoking, as we said. And this is a clear profile of a smoking home with several very acute peaks of pollution. And then those peaks drop down during the night period and then rise again during the day. Here you can see the image of the whole week. So day per day and all the hours here in the column. So this heat map is very illustrative and very beautiful. But not only all the pollution related to particulate matter comes from smoking. This is an image from another home that is not a non-smoker home, in which we see clearly 2 different periods of the day in which we have pollution related to particulate matter and is related to some activities that are conducted in this home, more probably cooking. Formaldehyde behaves very differently. So the emissions of formaldehyde are constant along time and are passive. So that means that formaldehyde comes from off-gassing of some building materials, furniture that is allocated in the room in which we are doing the measurements, etc. And as you can see here, the concentrations level remains more or less constant, but this pattern is also replicable for all days of the week and every hour of the day, so 24/7. Very quickly. So what we see here is that we have a problem. So the 50% of our dwellings are polluted. More than the 50% of our dwellings are polluted from one or contaminant or another one. But what is underwater is what I explained. So the sources of this pollution, mainly driven by particulate matter, and this is strongly associated to smoking, but also to other activities conducted in the home, and also for formaldehyde of gazing. But the question of the day, so what about indoor air quality and health exacerbations? So what the data suggests? So in short, if we want to analyze or to see if poor indoor air quality have caused more hospitalizations during the period that we followed our patients, I have to say no, but I will explain later on our hypothesis on that and why not. So if the utilization of resources or these crises or exacerbations of the patients are not related to indoor air quality, so what are they related with? So in first term, to clinical complexity. So here you can see all the patients and the hospitalized patients. And we observe differences in terms of clinical complexity when we compare these two groups. Also differences related to lung function and obstruction. And finally, differences between those groups and the previous history of health events. So hospitalized patients are prone to suffer more recurrently all-cause hospitalizations, unplanned hospitalizations, and have a total healthcare expenditure greater than the patients that have not hospitalized. So what is possible explanation for this phenomenon? As we saw, the intrinsic clinical factors dominate this risk. So in very advanced and chronic patients, factors like multimorbidity, the severity of the airflow obstruction, and the past of exacerbation history are the main drivers of hospitalization risk. Indoor air quality matters, but over longer time scales. So environmental exposures acts over long periods, and clinical effects often lag behind actual exposure. Chronic diseases evolve under the cumulative influence of the exposome. So indoor air quality can be a key component of this long-term trajectory. Some limitations of our study can also explain this finding. So the analysis focused only on severe hospitalized exacerbations, but we are ignoring or not looking at those that are mild and or moderate that can be managed at home without the necessity to hospitalize these patients. And finally, some technological limitations. So the study did not include infectious triggers, for example, and we didn't capture oxidant pollutants, as we said before. That can be a thing that can be improved in the future. So I'll take just 10 seconds more to read the conclusions, and I think we managed to stick in time. So first of them, low-cost sensors are feasible, reliable for short-term household indoor air quality monitoring and suitable for risk screening, but not for continuous long-term use. Impaired indoor air quality is highly prevalent, mainly driven by particulate matter exposure and strongly associated with indoor smoking and other household activities. The indoor air quality categories were not directly linked to unplanned hospitalizations. Instead, the outcomes were primarily influenced by multimorbidity, disease severity, and prior events. And finally, low-cost sensoring-based indoor air quality monitoring can serve as complementary tool within integrated care models for selected COPD patients and asthma patients, guiding preventive and educational interventions. And that's all on my side. Thank you.
Thank you very much, Ruben. I think it was really insightful and interesting to listening to how the research is evolving and which kind of correlations we have found so far. Not evident most of the time correlations, but a lot of probability that a certain attitude of a person within their own place, houses, etc., can in any case cause or accelerate let's say, some process in relation to well-being and health status. And now I would leave the floor to Alba Lopez. Alba is really hands-on what we are doing in K-HEALTHinAIR project. She's managing one of the it has on the nursing side one of the pilot sites that are actively contributing to the project's activity in Barcelona, and she's dealing with persons with respiratory diseases within the Hospital Clinic of Barcelona. So, Alba, maybe you can tell us something about your insights.
Yes, that is what I'm going to do. I will start sharing my screen first. Let's see. Can you see? Okay. Then, how Natalia said, I'm the nurse from the pilot of Barcelona in the framework of the K-HEALTHinAIR project, and I will be presenting our work on hybrid care for high-risk chronic respiratory patients that involves a nurse-led personalized intervention supported by advanced digital tools aimed at translating indoor air quality research into a better health outcomes. First, we have to look at the core challenge that we have here in the clinical area, that is a potential avoidable hospitalization. We know that almost 70% of these admissions are caused by cardiopulmonary conditions. More or less half of them are related to COPD or asthma patients. But why we do call them avoidable? Because with a timely community-based care intervention, they shouldn't happen. So the current problem is we have two of them. First, the definition of a community-based exacerbation that is often detected due to a subjective of the symptomatology reported by the patient. And second, the fragmentation that we have in the community, between the primary care center and the hospitals, that might create a blind spot during care transitions where which get an increased readmission risk. Our hypothesis is that the integrated care combining hybrid intervention can reduce this potentially avoidable hospitalization, improve the prognosis of these diseases, and engage the quality of life for those patients. So to address this, we thought about the hybrid care model. It's an integrated approach that combines human expertise with digital efficiency, and this model rests on three pillars: a nurse-led integrated care, an advanced digital support, and the last one, a health risk assessment for the personalization of the intervention. But first, let's get our context. Therefore, what I'm presenting today is a hybrid care intervention that is the operational model developed within the K-HEALTHinAIR project. Our initial work here is concentrated in a specific area of Barcelona, for which we enroll 205 high-risk patients. We divided the cohort into different groups, one comprising patients with COPD, with high comorbidities, and a second group with severe asthma patients from the Hospital Clinic of Barcelona. So the cohort has been followed up for 2 years, from 2023 until now. It's ongoing. But in parallel to this clinical follow-up, we employed a rigorous methodology that is called a Plan, Do, Study, Act, a PDSA methodology, to create a co-design process to reevaluate and refine the work we had in progress. We developed a study protocol that it was published this year in 2025, and consists the information that we use to establish the protocol, because the K-HEALTHinAIR protocol here in Barcelona is built in 4 components: the lung function testing, the household indoor air quality monitoring that was explained by Ruben, the data capture, and the digitally enabled management of those patients in the cohort. So this is where K-HEALTHinAIR, the project and the clinical practice converge in the hybrid care model, which serves as the operational vehicle for the project. The core challenge of the project was how can we get the indoor air quality related or to find association with health-related events. So we had to do an integrated approach to get this. So the goal of the study is to empower also the patient for self-management, to get the data flows from the patient monitoring with indoor quality sensor for prompts that are questionnaires, lung function testing at home, into an adaptive case management platform that consolidates the hybrid care management. And this facilitates also the work or the contact with a nurse case manager in this follow-up. So the result of the co-design phase were submitted recently, last September of this year. And now we are working on our last and final cycle, which has a specific focus on refining and optimizing this model. Now for this presentation, I will explain the information that we already had. So first, I want to explain the components of the hybrid care model. So let's go a closer look at the first component, that is the nurse case manager. That is the pivot of the entire intervention, which bridge the gap between the patient, the primary care attention centers, and the specialized units at a tertiary level, like the Hospital Clinic of Barcelona. We had to use an holistic assessment for each patient for personalization of care plans. We also try to do an empowerment of those patients with an education and self-management to foster proactivity during the project. And also we are trying to get an early management of detecting exacerbation. And for that, the nurse is the center of the intervention. The second component is the digital support that, unlike standard rigid software or platform, offers flexibility, multi-channel communication between the patient and the nurse through a phone application, and interoperability to connect all the cloud-based data. And last but not less important is the health risk assessment and modeling. That is the core of our strategy. Based on the risk modeling, we are going to try to define the right intensity of care for the right patient at the right time. And for that, we need these three pillars that are: first, do the profile to candidates and personalize the intervention for each one of them. Second, the management of the exacerbation to anticipate and prevent acute episodes. And last one, to use generative AI tools for the professional supports. So this last one is starting on in the last PDA cycle. So the work in this one is still ongoing. Then now before moving on to the conclusion, I think it's critical to highlight the key results obtained during this last PDA cycle, the third one, because we have successfully confirmed the feasibility and suitability of all core components within the hybrid care intervention. Crucially, we had the collaboration of patients, of health professionals to co-design this process and ensure a realistic formulation of this intervention that demonstrates acceptability among the stakeholders. That is a strong support, is a critical factor for a successful integration and scalability in a real-world clinical setting. So now, when we are working now in our last PDA cycle, the fourth, but in March of 2026, when we will try to move this to a clinical real setting, we will have to acknowledge that we will have some barriers to implementation. So we know that we will have to face diagnostic inconsistencies that you can find in the electronic health records. Also incomplete trajectories, so we will have a missing longitudinal data that will prevent us from establishing some baselines for predictive risk modeling. We will also have some gaps related to missing functional data, and for implementation process of digital tools, is almost impossible, or we will try to work around the technology issues to get to the digital part to each one of the patients, because it's difficult to get equity regarding the technology side. So it's a complex process that everyone should have to work on. So the refinement that we are working now on our PTS work is targeting a digital usability and sustainability adoption through innovation, that we have 4 main topics related to digital support to resolve the digital issues, related to trying to implement generative AI or conversational agents, or easier steps for the login to the application and other digital tools. Also the oscillometry, we will need new guidelines for the patient to do and perform a home-based use and data-driven parameters for moderate exacerbations. The third one will be to do a risk assessment and EA-driven identification of high-risk candidates for clinical decision support, and also a sustainable adoption that will need a training programs, KPIs, and also a value assessment with a keen to play aim. So to summarize all the presentation, this leads to the conclusion, and I think it can be summarized that we are on our way to move from pilot to practice, even still if we are on a pilot, that we need the clear strategic path forward is to do a transition to this research initiative into a routine clinical practice, and our immediate focus is in the Barcelona Esquerra district to full operate a hybrid care approach into existing care circuits. Thank you so much for your attention. I'm happy now or later to take any questions.
Yeah, thank you very much, Alba. I found it really interesting, and I think a number of questions will and are coming out because this transition, obviously, from pilot to practice really attains to the concept of sustainability of the intervention, and apart from a financial, let's say, issue related to the support, there are also a number of barriers, as you said, practical barriers that should be overcome, but also taking into account the pivotal role of the nurse played in this hybrid care model, which I think it's very interesting to investigate more. But before giving the floor to questions, I will lead the mic to Simone Deled. Simone is involved again in another pilot site of the K-HEALTHinAIR project, the one based in Rotterdam. And while there are some similarities in between Barcelona and Rotterdam in terms of interventions and activities implemented there, you also have a focus on nursing homes, and so really on elderly, let's say, persons in your district. And Simone will tell us something about the short-term impact on health of the elderly that he has observed so far. The floor is yours, Simone.
Yes, thank you. Right, thank you, Natalia. So my talk will be about the indoor air quality and short-term health effects in older adults. These I'll be presenting preliminary results, and I've been doing this with my colleagues Li Chen-Yi and Amy van Grieken. So a little bit about the background. So the goal of this of our study was to determine factors that are associated with indoor air quality related symptoms in older people living independently at home in Rotterdam, and with a focus on short-term symptoms. And what we mean with short-term symptoms are symptoms that people experience inside their homes on a daily basis. I'll talk about it more in the next slide, but you have to think about symptoms that are related to headache, blocked or runny nose, dry, itchy skin or skin rashes, but also dry, sore throat or eyes, wheezing or coughing, and fatigue. And these are the short-term symptoms that we focus on. And these short-term symptoms, they're related to, or they can be related to something called sick building syndrome. However, in our study, we do not have the right amount of evidence to like pinpoint people having sick building syndrome. So that's why we call it short-term health effects. And we asked it to people multiple occasions, but since we only have one time point analyzed, we will not be doing the longitudinal study yet. But we asked people, did you experience the following symptoms? And we have 8. And so we asked people, do you have headache, fatigue, dry eyes, itchy eyes, runny nose, blocked or stuffy nose, dry throat, and dry, itchy, or irritated skin? And people could answer each of these 8 symptoms separately, and then I could say, yes, I experience at home, yes, outside, yes, in other places, or no, not at all. And people, we asked people to fill in these questions 5 days in a row. So then, in the end, we would have 5 days in a row of people filling out whether they have these symptoms. Now we categorize these symptoms into something that we call general symptoms, like headache and fatigue, mucosal related symptoms, so dry eyes or dry throat, and then skin symptoms. And we took these 3 main categories or groups of symptoms, and then we tested, which factors are associated with these groups of symptoms. And we did this, like I said earlier, in a cross-sectional study. So we took one time point because we have multiple times in which people answer these questions, but we only took one to analyze. And we took continuous IAQ monitoring data, and we aggregated it on a monthly basis. So what we took is that we said, okay, the first day people filled in the questionnaire with these groups of symptoms, and then we took a month around this first date, and we aggregated that. And for the analysis, we split that into a daytime and a nighttime to sort of see if we could analyze whether the indoor air quality during the day we suspect it to be worse than during the nighttime. So that's why we made this distinction. And also, we said, okay, the nighttime could maybe be some sort of a control for the data. Not an official one, but you know. And then we also did, we have some descriptives and multiple logistic regression. I'm I want to iterate again that this is these are preliminary results. So we've not finished the study completely yet, but we'll do this later on. But please bear with me. But to continue, you see here, yeah, our baseline table, and I want to drag your attention to the groups of symptoms, so the general mucosal and skin, and we could see that during these 5 days, like around 50% said, okay, yes, I do experience general symptoms or mucosal symptoms, and about a third said, okay, I have skin symptoms, or I do experience skin symptoms. And I also want to drag your attention to the sex of our participants, which is roughly the same amount, so around 50%. And then also want to drag your attention to the lowest part, namely that we also asked people, well, okay, in your home, are all the windows, can they all open? Can they let in fresh air? And we went around and we had a look at, okay, do people have mechanical ventilation, and do they have this not only in the bathroom or in the toilet area, but also around the whole house? And also, do people have an extractor fan? And this is something that you have above your cooking top. But also not all people had this extractor fan above their cooking top. And then also important characteristic, of course, is the type of cooking top. So we saw that in our group of participants, the most, around like 70%, they have an electric cook stove, and the rest, around 25, have a gas stove. So they cook on natural gas. These are some of the factors that we thought were important. You might be wondering, okay, where's smoking or being exposed to passive smoke? We took those out of the model. That was just because in our sample only a few people smoke, so like 1 or 2, that gave really weird results. The same for pet owners, so people having pets, only a few of those were in our sample. Then here the whole table with the logistic regression. I want to point your attention to a few. So we can see that during the daytime IAQ, we can see that, okay, when there's a higher humidity, people report a lower odds of skin symptoms, so like dry, itchy skin, which is something that we would expect. We also found a significant education level. So, but this is somewhat weird because there are like the confidence intervals are quite large there. And we also found that the number of chronic conditions came back significant, which also is in the line of expectations, especially seeing that it's also in the general symptoms part and the skin symptoms. So this is also something that we would expect. This is something more strange. So if people had an extractor fan, they had lower odds of general symptoms. I said strange, but this is something we would expect. But also, if people spend more of the hours of the day indoors, also the odds of skin symptoms would decrease, which could be a bit weird, but it has to be related with then the humidity. And during nighttime, we actually see the same. So the same story with the humidity. and the education level, and also the number of chronic diseases, the extractor fan again, and then the um, um, number of hours spent indoors. I see that I have to hurry up, but I have some concluding statements. So we see that the higher humidity caused lower odds of skin symptoms, which is something that we expected. Something that I have to mention is that the small number of people smoking and being exposed to passive smoke caused us to exclude those from the model, and the same for pet owners, and that we would also want to do a longitudinal analysis to examine the data further. Yeah, these were it. I see that my time is finished, so I hope you have some questions for me, for us. Thank you.
Thank you very much, Simon. Yeah, maybe we can start. We can start with you. So, what did you? I mean, which are the first impressions that you gather from the study, and how much we can rely, let's say, on the correlations that you have identified?
Yeah. So something that we would expect is this humidity and these skin symptoms. That is something that we on the we expected to see. We did we thought there would be the factor of cooking top. So cooktop type, so electric versus gas stove. We expected that to be more prominently, and yeah, we also expected like higher PM and higher formaldehyde to also play a role, but this is not something that we have seen yet. And then the same is for like, yeah, if people can open windows, the more fresh air comes in. But this is also something that we've not seen back yet. And I must say, these are preliminary results, and we still need to analyze further. Also, like interaction terms and imputations is something that we need to refine, and we also have a small sample size, so this is also something to take account.
Sure. But this brings me to mitigation measures. Maybe Ruben, you can say something about how can we mitigate in normal life, let's say in day-by-day life, how we can mitigate the adverse effects of poor indoor air quality.
Yes, so at least from what we learned from our data is that the pollution indoors, most of them or a great part of them is derived from human activity, from the things that we do and perform at homes. So most of these actions targeting the mitigation or reducing exposure must also target changing or pursuing behavioral changes. So in this case, in our sample, a very large amount of the homes that are heavily polluted by particulate matter. So the main source of pollution was smoking. So here, clearly, the most easier and effective way to reduce this exposure is enrolling these patients or trying to endorse healthier behaviors to them and encourage them to quit the habit that is causing which is the main source of pollution at home. A part of the other benefits that it can have in our health. But these sort of activities, also increasing ventilation and having a healthier habits of ventilating, renovating air, all these activities are very easy to do, easy to implement, and can have a very positive impact on indoor air quality at homes. On the other hand, we have another pollutant, or we analyzed another pollutant that we saw that have a very different behavior, that is formaldehyde. And formaldehyde comes from passive emissions that came from, as I said, building materials that are present in our homes that we cannot change, or some furniture that we have there that are generating these kind of compounds. So in those cases, what we are trying to do, just with a few selected homes in our protocol or in our cohort that have shown increased levels of formaldehyde and also particles. So we prioritize homes that have mixed contamination from these two pollutants to see if implementing or deploying air purifiers at home that are equipped with two kind of filters that we are testing, HEPA filters and carbon activated filters, are enough to remove these sources or these pollutants from the environment. So we are pretty confident that we will be able to do so for particulate matter. And what will happen with formaldehyde, I think it's still a question mark, but I think we will reveal soon once we've finished with this short protocol that is still ongoing. So.
Yes, thank you, Ruben. So small gestures in everyday life that can reveal greater impact, let's say, on our health status. Alba, we have just minutes to go, but you were mentioning, I mean, this hybrid model that you have presented. I think that he's got very important positive impact on the patients. So maybe they feel much cared than in normal practice, let's say, but it also brings a lot. So it can bring, and this is the question, additional burden on the duties of a nurse can have in the ward or in the outpatient clinic. How can you manage this, or how are you managing this? Let's say
that's hard to answer because I'm in charge of all the involvement with the patient. Is difficult because each patient has a different way to approach. You have to personalize, and you need to record every intervention you have had, all the incidents, all the difficulties that you had, and sometimes it impacts in maybe the quality and how fast you can do the intervention, how fast I can go to see the patient, or how fast I can resolve a technical issue if I had one with the monitor, the environmental monitor. No, but I think that's, even if I got delayed because of the burden of the pilots and the work, the patient understand that. Is patient with that because he knows that you are trying to involve him in something where he is the main person to get in the point of view. No, so it's hard because I think I should it would have been a better work with another nurse, because I think we will have get more information or do the intervention faster for the recruitment, for example, or for the measurement. But I think that is to try to find a balance and distribute the workload, and also to emphasize the work that you are doing to the patient, so he knows that you're working with him, but also with other people, and you have to make it work, to make everything work.
Yeah. Thank you very much to all of you, and I think it was a very nice add-on in this discussion related to our project, and get to know a bit more about indoor air quality. As I said, this is the second webinar organized by us. There will be some more before the end of the project. take the occasion also to announce the final scientific conference of the project that will be in person in Spain, in Valladolid, hosted by our coordinator at Cardiff. And I would like to thank a lot all the people that joined us today. Please follow us on our project website and the social media for additional update. And I hope to see you soon on this channel or in other channels in the near future.